So our next speaker is Dr. Sònia Pernas. She's a medical doctor. She studied in Barcelona, completed oncology also in Barcelona at Hospital de la Santa Creu. And she joined in 2004 the Breast Cancer Institute at the Catalan Institute of Oncology. And since 2013, she's been the head of the breast cancer unit of this institution. She's one of our pilot, so she's going to be talking about her experience with OncoKDM, with Salty.
Bonsoir, je suis désolée, mais je ne parle pas français, so better I change to Spanish, sorry, to English. If you want me to talk in Spanish, it would be perfect. On behalf of Salty, I would like to introduce you to the AGATA screening molecular program. The aim of this study is not only to know more about this complex tumor biology, but also we want to contribute that more breast cancer patients, metastatic breast cancer patients, can be referred to being treated with target therapy depending on her molecular profile. So when we treat patients, in this case metastatic breast cancer patients, we have to take into account not only efficacy, but also the side effects, toxicity. So some patients will benefit from treatments, others will not at all, and some others will have severe toxicity. And probably the main reason of that will be based on their molecular profile. So we would like to get the right treatment for the right to the right patient. And as you know, these are all the molecular screening programs that are worldwide. The first one was the French group, the Saphir one, and then Dr. Zarzapas will talk about the Aurora trial that is worldwide. And this is not the first, but at least the AGATA trial is the first molecular screening program that we have in Spain. The study was designed to include 260 patients, metastatic breast cancer patients, and the samples collected once the patients have signed the informed consent, those samples that we recommend to send metastatic samples, and if they are not available, then samples from the primary tumor. Those samples are sent to the 3 labs in Spain, and when those samples are processed, depending on the results, then a panel of experts that I will introduce you afterwards review these results, and based on that, we'll do a recommendation on treatment. And then this recommendation is the oncologist that follows that and treats that patient can follow or not that recommendation depending on the status at that moment in the patient and the ability of a clinical trial at that moment. But now, with 260 patients, it's only 1.4% of all the metastatic breast cancer patients. As you know, breast cancer patients are increasing, not only because there are new cases, but because patients live longer, and this is good news. Not only because they've lived longer after being treated for early breast cancer, but also patients with metastatic breast cancer live longer, more years, thanks to the advance of new drugs. So this is just a pilot study to have the information and of those 260 patients. What are the objectives of this study, of the AGATA study? The main objective is to see the effectiveness of the program in assessing patients to clinical trials based on her molecular profile, but also to see what are the characteristics and the percentage of mutation in these patients, mutations that are potentially actionable. And also because this is a pilot study and was the first study in Spain, we wanted to look at the feasibility of the program at the national level and also to identify potential barriers. On the other hand, we wanted to develop the most appropriate panels and sequencing methods for breast cancer patients, and also the effectiveness to include patients in target clinical trials depending on her molecular profile. And also, and as recently published in the Moscato trial, that we wanted to see if those patients that are referred to a clinical trial with target therapy based on her molecular profile, if it live longer or not, compared to patients not assigned to clinical trials. Not only progression-free survival, but also overall survival, that at the end is the most important thing. Those are nowadays the 10 centers participating in AGATA trial in Spain. In Dutch, you can see the 3 labs where the samples are referred to. One in Barcelona at the Vall d'Hebron Institute of Oncology, another in Madrid, the 12 de Octubre, and another in Valencia. In those labs, the majority is using next generation sequencing, and in one, there's the sequenom genotyping is performed. Those are the AGATA team, all the people that are involved in the trial. On the top, you can see all the people from the central office, very committed people in the trial. And here you can see all the panel of experts. We have Dr. Mauricio Scaltriti as a molecular biologist expert, Dr. Ana Vivancos of genomics specialist, also an expert on early phase development, that is Jordi Rodon. Also, Dr. Aleix Prat as translational oncologist expert. Also, we have a pathologist, breast cancer pathologist, that is Dr. Octavio Burgues. And then Dr. Eva Ciruelos as myself as principal investigators of this study. And what we have done until now, well, the target, as I told you, was 260, and until now, 234 patients have been already evaluated. Not all the patients included can be evaluated, and the main reason of excluding patients is because of samples. Not always there's a sample available, or in other cases, it's because the quality of the sample, maybe there's not enough tumor cells or the DNA is not valid. That's the reason where some patients are being excluded. And what are the results? Where in more than 50% we can find a mutation, but the most common one in breast cancer is mutation in P53 that until now is not a targetable mutation, but even that we have found almost 50% of patients with a potential actionable mutation. The most frequent one, PA3 kinase mutation. And let me explain you just 2 cases of my hospital, 2 patients that were included in this study. One was this 50-year-old that when she was 39-year-old, she was diagnosed of a breast cancer. and treated with surgery, radiotherapy, chemo, and also endocrine therapy. 7 years later, she relapsed with bone disease, bone metastasis, and some little liver metastasis. She was treated with some line of hormonal treatment, 3 different lines. With the first one, she was more than 20 months without progression, but at the end she progressed and was being treated with a second and a third line therapy. As you can see, the time decreases, where the progression-free survival was less. And then this patient was included in the AGATA study, and we found a HER2 mutation. This is different, the HER2 amplification or overexpression that you know in breast cancer it's 15%, but the HER2 mutation is a very rare mutation, it's less than 5%, but this patient was included in a clinical trial, in a basket trial with neratinib. This is a tyrosine kinase inhibitor. And just with this, no chemo, and she was treated for 9 months, and then she progressed. You could think that 9 months is not enough, and it is not for a metastatic breast cancer patient, but these 9 months for the patient were really, really important and with very good quality of life. And just with biological treatment, no chemo. So you can imagine that the side effects are not the same. And another case was a 62-year-old. She was a nurse, and she presented with a bilateral breast cancer in 1996, treated with surgery, radiotherapy, and chemo. She presented a local relapse in her right breast in 2002. It was ER positive, HER2 negative, and was treated again with surgery, in this case mastectomy, and then she received adjuvant chemo and also endocrine therapy. And I'm sorry, there's a mistake. 10 years later, in 2012, she developed a metastatic disease in her bones, and then she was treated with hormonal therapy. The last one was fulvestrant, and with this treatment, she was for more than 3 years without progression. That is quite impressive. And then we include this patient in the AGATA study, and this patient was found to have an AKT mutation, and then she was sent. We sent this patient to another hospital that they had a target therapy with an AKT inhibitor, and even though that this patient was treated with a fulvestrant previously, and she had progressed to fulvestrant, with this combination that it was an AKT inhibitor and fulvestrant, she presented a partial response, and she's ongoing on the trial with maintained partial response. That is quite impressive, thinking about that it's just biological treatment, no chemo. And this is a third line of treatment, and this is her CT scan, and as you can see in the sternum, there was a lesion, and she's with a partial response, maintained it for more than 12 months, and she's ongoing. So you can see that it's something that it's a benefit for the patients, not only help us to understand breast cancer biology, but also patients can benefit from that. But as you know, tumor biology is really, really complex. We have all this amount of information, but we know already that breast cancer is a heterogeneous disease, and not only it's an heterogeneous disease between patients, but also there is an intratumoral cellular heterogeneity, also in intra-patient tumor heterogeneity, heterogeneity, sorry, and the characteristics of the tumor can change on the metastases between the primary tumor, and also with time. No, tumor characteristics can change with time. But also, technology is improving, and this helps us to process many samples and to have all this information. So this is great. So we have amended the protocol, and we have included not only DNA analysis, but also gene expression analysis and proteinomics. And in a brief time, we hope we will include as well DNA methylation to provide a more comprehensive molecular profile of breast cancer tumors. So we have included new objectives to the study, just to not only to describe the gene expression profile and also protein expression profile, but also which is the relationship between gene sequencing results and gene expression and proteinomic analysis results, and to determine if whether this relationship implies at the end that more patients can be referred to a clinical trial with target therapy. And the most important question is, all this knowledge will change at the end our clinical practice? We don't know. And there's the challenge. One of the most important challenge that we have now is how can we integrate all this amount of information, DNA, proteinomics, genomics, also the methylation information. And on the other hand, when we find a biomarker, what is it telling us? Is this a driver? What does it mean? And here's the OncoDNA solution for the AGATA study, to integrate all this data, all this different information to increase the molecular tumor characterization and also to identify the driver genes. That is the most important thing. It's like this, when we have all this information, it could be a mess, like the Marx Brothers cabin a night at the opera, and with a solution of OncoDNA, it's like here, you can identify which are the principal actors, and what are their function. So it's important to have all this data integrated, and it looks like this. This is just, we are working on that. We just start the collaboration and doing the analysis. So this is an example, and it looks like this. This is great to have all this information included here, not only the analysis, but also the quality control and where the biomarker is, where the pathways involved with this biomarker, and also what are the drugs actually that have been approved for these biomarkers or others that are in development. And what is very, very important, which clinical trials can we have to refer our patients that they can from a target therapy, and to have all this information helps a lot, and it gives all the reasonable and we understand all this data. So what's the future of AGATA? We wanted to do that, to have all this information collected from not only those 260 patients, but we would like to offer this to the majority of our metastatic breast cancer patients. But as you can see, one of the most important challenges as well is that this is very, very expensive. We need funding for that. This is actually the funding we have. But our final objective will be that the majority of breast cancer patients could benefit from this program. And also, as you already commented, to share all this information, to share all this knowledge with other countries, and with the objective that more patients can integrate all this information, not only to improve our knowledge in breast cancer biology, but also to help our patients to a more rational and target therapy, because at the end, what we wanted to do is that our patient could live longer. Thank you very much.